we are aggressively breaking this material down into 5 distinct modules. We'll move linearly, starting with foundational reconstruction principles and going straight through to acute facial and hand trauma management. Section 1. The reconstructive ladder and foundational principles. Think of the reconstructive ladder as your core hierarchical framework for planning literally any surgical wound closure. The fundamental rule here: always choose the simplest approach that gets the job done. You want to start way down at the bottom with secondary intention or primary closure, right? You only climb up to those really complex rungs like free tissue transfers that need microvascular anastomosis when it's absolutely necessary. Keep it simple whenever you can. Now, before you even think about moving up that ladder to grafts, you might actually need to prep the wound bed. This is where negative pressure wound therapy, or NPWT, comes in. It's an incredible tool to promote granulation and get that wound ready for a graft. But, and this is a huge but, you must know the hard contraindications. Never, ever apply NPWT if there's malignancy, ischemic wounds, active infections, or if the tissue hasn't been adequately debrided. Moving right along to Section 2, Skin and Tissue Grafts, our coverage solutions. Okay, crucial concept here. A graft has absolutely zero intrinsic blood supply. Its survival depends entirely on the vascularity of the underlying bed. So, bare tendon or desiccated bone, yeah, they simply won't support a graft. When you're choosing a graft, watch out, because exam questions love to heavily test contracture rates. Here's the deal. Split thickness grafts suffer severe secondary contracture. We're talking around 40%. But full thickness grafts, they're the exact opposite. They have massive immediate primary contraction, but practically zero secondary contraction once they're fully healed. And honestly, the anatomy perfectly explains this behavior. You see, split thickness grafts just take the epidermis and a little piece of the dermis. Full thickness grafts, on the other hand, take the entire dermis. Actually, because they contain all that deep dermal tissue, full thickness grafts have to be aggressively defatted before you place them, just to make sure they get optimal take. You absolutely must memorize this healing timeline. Think about it. How does a graft even survive the first 48 hours without any blood vessels? Well, days 1 and 2 rely entirely on imbibition, which is just a fancy way of saying nutrient diffusion directly from the wound bed. Then, days 3 to 5 hit the inosculation phase, where the capillaries of the graft and the wound bed finally start to align. And finally, after day 5, the graft truly revascularizes through capillary ingrowth. Section 3. Flaps and tissue expansion, where we maintain the blood supply. So, unlike a graft, a flap is defined by moving tissue while actually keeping its blood supply intact. Let's look at the mechanics. A rotation flap pivots directly along an arc right into the primary defect. But a transposition flap, that one has to jump or move over intervening intact tissue to reach the defect. And because it does that, it creates a secondary defect at the donor site, which, you guessed it, typically needs a skin graft to close. When you're dealing with complex local anatomy, strict precision is the name of the game. Take bilobed flaps, for example. They use a primary flap for the main defect, and then a secondary flap, which is exactly half the width of the primary, to shift all that tension into areas with looser skin. Then you have the classic rhomboid, or Limburg flap. This one relies on very strict geometry, exactly 60 and 120-degree angles to perfectly optimize tension and tissue movement. Let's talk tissue expansion for cases like burn alopecia or breast reconstruction. Your absolute target goal here is always 130% of the defect size. You need that extra margin. And you must strictly follow the timeline. Place the expander perpendicular to the expansion direction. Then wait 2 to 3 weeks before you even start inflation. And critically, you have to wait another 2 to 3 weeks after reaching your desired volume before transposing the flap. Doing this allows the skin time to soften and really decreases the risk of contraction. Pivoting now to Section 4, Acute Facial Trauma and Emergent Assessment. All right, get ready for some rapid-fire, extremely high-yield clinical pearls. Number 1, always rule out a C-spine injury. About 10% of facial trauma patients have one, so don't miss it. Make sure to test all 5 facial nerve branches and check those extraocular movements. Now, if you spot any signs of orbital compartment syndrome, we're talking proptosis, severe eye pain, or acute vision loss from a retrobulbar hematoma, you have to act fast. You must immediately perform an emergent lateral cantholysis. Oh, and always check the septum with an otoscope. If you see a septal hematoma, evacuate it right away to prevent permanent cartilage necrosis and a saddle nose deformity. Finally, we reach our most heavily tested module, Section 5, Acute Hand Trauma. The literal first step in any vascular assessment of the hand is the Allen test. It is completely mandatory. You have to verify that the superficial and deep palmar arches are totally intact before you do any intervention. It's simple. Have the patient make a fist, manually occlude both the radial and ulnar arteries at the wrist, have them open their hand, and then just release one artery at a time to watch the color return. Now for unambiguous nerve testing, you really have to isolate the nerves. To isolate the median nerve's intrinsic motor function, have the patient abduct their thumb completely perpendicular to their palm. For the ulnar nerve, you want to test the interosseae by asking them to cross their long finger right over their index finger. And for the radial nerve, simply test sensory function on the dorsum of the first web space. Whenever it comes to splinting pretty much any hand fracture or ligament injury, you're going to use the intrinsic plus position. So why does this matter so much? Well, it specifically places the collateral ligaments of the fingers in their absolute longest possible state. This is totally crucial to prevent catastrophic permanent joint stiffness while the hand is immobilized. Trust me, you do not want a stiff hand. When we look at the palmar side, the specific zone of injury completely dictates your flexor tendon's surgical management. You really need to pay immediate attention to zone 2. This is the area located right between the proximal A1 pulley and the insertion of the flexor digitorum superficialis. The reason zone 2 is so critical is that historically it's known as no man's land. Surgical repairs in this specific zone carry a significantly worse prognosis. Why? Well, it's all because of the dense scarring that tends to form there, which severely restricts the tendon's ability to glide smoothly within the digital sheath. Conversely, over on the dorsum of the hand, you really need to know your extensor zones. A forced flexion injury at zone I, right over the DIP joint, will rupture the terminal tendon and create a classic mallet finger. Moving proximally up to zone 3 over the PIP joint, an untreated injury to the central slip, that will inevitably lead to a boutonniere deformity. That's PIP flexion coupled with DIP hyperextension. And at zone 5 over the MCP joints, always assess for a sagittal band injury to prevent the tendon from subluxating. To close out this rapid review, I want to leave you with a quick clinical challenge to test how well you've synthesized all this material. If your patient has an acute wound bed with bare tendon and completely desiccated bone, meaning a simple skin graft absolutely will not survive, how do you utilize your knowledge of flaps and the reconstructive ladder to get definitive closure? Think hard about the blood supply required there. Good luck, and I'll see you in the next explainer.